Ryan Stanton here with ASEP Frontline, and today with Dr. Deborah Diercks and Dr. Bruce Lowe, and we're going to talk a little bit of Airway, renovate, and that's more than a house, fixing up the house. That's a trial that came out. We're going to talk about that a little bit in terms of airway management, the crashing airway, and some of the tools and options we have. I think the toolbox really expanded during COVID because of the interest in having other methods of airway management, and even though it existed, I think it really gave an opportunity for a lot of kind of where it works, where it doesn't work opportunities. So this is cool because it's one of the biggest things we deal with on any given day in our shift is going to be airway management, and being able to do that, providing the service and what's correct for that patient based on their needs is paramount. So Dr. Diercks, I'll start with you. Just first, give a little background on yourself, and then we'll roll from there.
Hi, I'm Deb Diercks. I am an emergency physician in Dallas, Texas, and work at UT Southwestern and get to take care of patients also at Parkland Hospital.
Welcome, everybody. My name is Bruce Lowe, emergency physician in Norfolk, Virginia. Work at Sentara Norfolk General, which is a teaching hospital, but also do work at the community, including our freestanding emergency departments.
And they're here today. I know both of them from outside the world of podcasting. So good to have you both with us here. And so, Dr. Diercks, first and foremost, give us an idea of what we're renovating.
Yeah, so Renovate is a randomized trial of high-flow nasal cannula versus non-invasive ventilation. That really was one of the few trials that actually enrolled patients in the emergency department, where about 40% of all patients were either enrolled in the ED or in a ward, and the rest in the ICU. It was done in Brazil. It's prospective, but it really provided some unique insights on not only like the traditional COVID patients that you mentioned that we've become really comfortable with when we use high flow nasal cannula, but also other populations such as pulmonary edema, some just non-immunocompromised ARDS patients, some ARDS patients, and COPD.
So get us a little breakdown of kind of, it gets the idea of the non-inferiority of high flow nasal cannula, and kind of break down what that means. If you're looking at research and data, when you're comparing to technologies or interventions, what this all means and kind of that take-home message of the trial.
You know, I think that's a great point. Non-inferiority is really a statistical design to show that something is as good as or no worse than another modality. So it's not going to say it's better, and you can't take away from this trial that it's anything superior, but it really is, can you use, in this case, high flow nasal cannula in a way that isn't worse than non-invasive ventilation? So it's not going to give that answer what's better. It's the as good as kind of approach.
And with that in mind, and I'll let you both kind of dive into this one, what does that mean with regard to airway management? I mean, when I was going through in residency, you had your nasal cannulas, you had your non-rebreather masks, you had your Venturi masks, then you jumped to intubation. Like, boom, here we go. There wasn't even a ton in that case in the emergency department setting, and especially the pre-hospital setting, of using CPAPs and BiPAPs. So kind of dive into what this means in terms of those options for management of patients that are coming in potentially over the next several months as we jump into our infection seasons.
I'm so looking forward to COVID and flu with our EDs so full. But I think overall, I think this provides another tool in our toolbox that we should feel comfortable using. Now, we have to acknowledge that the Renovate trial did not show non-inferiority in immunocompromised patients. So the hypoxic immunocompromised patients, it didn't show non-inferiority, and that arm was halted. So let's just take that group out of the conversation. But when it comes to COPD patients and patients with pulmonary edema, COVID, or non-immunocompromised, we now have something we can go to if it's your first line, because patients may find it more comfortable, or if patients can't tolerate non-invasive ventilation. And I think that's really helpful because we're often kind of stuck with going to a single arm, then we know patients can't tolerate it. There's nothing worse than having somebody needs to be on BiPAP, and the first thing they say to you is, "Don't put me on that." Right? And then you're stuck, right? And so I think this does provide another option for us to actually use it in cases and feel comfortable with it. And I think that's the key to the study.
What I like about the study is actually a fairly large study. Over 1,000 patients were in the study. And if you look at the other literature that compared high flow nasal cannula with BiPAP or other modalities, I mean, tend to be really, really small studies. So while the study's not perfect, and no study's ever perfect, it does kind of add a lot of credence to say that at least high flow nasal cannula, performs, at least in the study populations that Dr. Diercks had mentioned, equally as well as non-invasive such as BiPAP.
And patients do tend to tolerate it a lot better. I mean, Dr. Diercks, you mentioned the BiPAP patient. I mean, there's the two things that make everybody universally claustrophobic in the emergency department. It's a BiPAP and an MRI machine. And so, I mean, those are really kind of the things that we're dealing with here is not only is BiPAP something that can be helpful, but I mean, it's the tolerance of a lot of these patients is questionable at best. So how do you take this trial and kind of implement it or put it into practice? You've already mentioned we're going to throw out, not literally, but figuratively throw out the immunocompromised patients who come in that are puffing away. But as you implement this in your practice, is this something that's going to change the way you practice, or is it just more for each patient as they come in?
I think the study opened up a few populations that I didn't jump to or think about high flow nasal cannula, and that is in particular the pulmonary edema patients and those patients that we can temporize as we get their blood pressure down, give them some nitrates. This may be an ideal patient because those patients are usually huffing and puffing, don't want the mask on their face, and they may do better at that. And I think building on the study, it may actually show there is some benefit to the high flow nasal cannula. Not this one can't, but it alluded to some different outcomes. So I think that group, I'm more willing to jump to nasal cannula from this study. I also like this study because if you read the supplements, and I know no one reads the supplements, but if you do, it kind of tells you how to escalate therapy and how to de-escalate therapy on nasal cannula by looking at respiratory rate, making sure you bump up, you go up on your O2, then go up on, and how you elevate your pressures to really get the maximal benefit. So although, again, I'm not a fan of diving deep into supplements, I think this one really provides a pretty clear mechanism on how to actually use nasal cannula and even non-invasive ventilation as they did in this study. So we're using it appropriately. And I actually think that's very useful.
And Dr. Lowe, is this something that, with this coming out, is this something that will change your practice there in Norfolk, I guess, when half the Navy comes in with their illnesses this winter?
Yeah, absolutely. And I would say same with what Deb had mentioned. I think we all knew that the toolkit for high flow nasal cannula was there. And depending on what your experience is and, what the comfort level within your hospital, with your RTs and so forth, how much did you really use it? But I think this really opens the door to say, it's actually okay to use it in probably more areas than you typically would have in the first place. And as mentioned before, patients tolerate much better than BiPAP. One of the things that really opened my eyes is, when we teach residents, students, and nurses, we actually will try on the different types of modalities. We try on the high flow nasal cannula, we crank it up. How does it feel? We put on the mask for BiPAP, and I will tell you, it is really unpleasant to put on that BiPAP mask and have that air blast into your face. So, I totally understand from a patient perspective, what it's like to experience that. So I think expanding that toolbox is really key.
All right, so let's dive into, because not only do we have the research with the Renovate trial, but we also now have tools to support the clinicians out there, the physicians. So Dr. Lowe, dive into that toolbox / kit / assistance that's available from ACEP.
Yeah, so thank you for that. One of the things that we realized was that you have all these tools, right? You have all these options. You got high flow, oxygen. You got high flow nasal cannula. You got BiPAP. obviously intubation or invasive mechanical ventilation. But if you're not used to using these tools quite often, or maybe you don't have the support, when I work in a freestanding emergency department, we don't have respiratory technologists there to kind of guide us or help us with the machines or settings and things like that. And it can be pretty daunting. Oh, there's this tool. I heard this great podcast with Dr. Stanton that talked about using high flow nasal cannula. But how do what do I do with the settings? How do I maneuver the oxygenation and things like that? And so what our goal was to create something that's simple and easy to use for the end user that they can pull up and say, okay, if I got somebody in respiratory distress or respiratory failure, here are my tool options, right? Again, high flow nasal cannula, non-invasive positive pressure ventilation like CPAP or BiPAP, and obviously invasive or intubation. What do I start the settings at, right? If I do high flow nasal cannula, if I have problems with oxygenation, what do I tweak? There's really two knobs that you do for high flow, right? There's the flow rate and there's your FiO2, right? Does it make a difference? What do I do? So we want to make something that's kind of simple, easy to use, to reference kind of in real time for the end user.
And I would always encourage folks that if you've not tried the high flow nasal, I know a lot of the vendors will let you try them when they're there, even donating to certain charitable organizations if you do it. It's not. You'd think if something's blowing in your nose at 40 to 60 liters per minute that your eyeballs would blow out, but it's actually the humidification and the warming, the heating is actually makes it very, very tolerable. So much more so than putting that mask over your face. So Dr. Diercks, you mentioned the supplement. You've already lost 80% of ER docs at that point because it's not the summary, the bullet points, and now we're actually reading the article and the extra stuff. But let's say we got it. So putting together the tool, the respiratory distress tool, with that supplement that kind of talks about that progression of airway management in folks that are coming in front of you.
I think Bruce, the tool is amazing, right? It's easy to use, clear, and exactly what an ED doc wants. And in many ways, it just builds on that supplement and puts it in an easy to understand way, right? So I think the reality is ED docs aren't going to read the supplement. And so I think the tool is probably the best way to do it. I think just in general, my keys from that supplement were follow your respiratory rate. That's going to really help you on worker breathing. That was used to really reassess, and your oxygen saturation. And I think those two parameters are key when you use high flow nasal cannula to make sure you assess whether it's working effectively. And then I think, the respiratory distress tool is going to kind of get you through the gate and in a clear, easy manner that any emergency physician can use. Because the challenge in the community hospitals, those who aren't kind of used to it, and that just provides the roadmap to get it started, as Bruce already mentioned.
So Bruce, talk a little bit about where all this is kind of housed, because if it's just like any other tool, design tools designed for emergency physicians, so the easy kind of click, very simple drop-down boxes, expanding, kind of working your way through. So it's not just something that's just there, like a dumpster of information having you wade through it. It is very very click-friendly in terms of finding what you're looking for. Where is this type of tool housed and access to it?
Yeah, so it's on the ACEP website. You don't need to log in. It's not behind a firewall, so it's open to anybody who has access to the internet. And if you just look up or Google ACEP respiratory distress tools, it will pop up, I think, top of the search. And what's nice about it is as you go to the front page, they have a bunch of drop downs, but it's really broken down to several different categories. And you can see already up front, it's, non-rebreather, which I think we're all familiar with, high flow nasal cannula, non-invasive positive pressure ventilation like CPAP, BiPAP, and then intubation. We also thought too that, ideally, if you had to get to intubate somebody, those people get up and out of your emergency department very quickly. Well, we all know the reality is, especially this day and age, sometimes they linger. And so we try to put some pearls in each of the sections too about, what could go wrong, how to troubleshoot things, whether it's high flow, whether it's BiPAP, or even if somebody's on the vent, you have to go into that pathway. Maybe some quick things that you can do that you don't have to be, a critical care trained, fellowship trained physician to be able to manage it in the emergency department very quickly. And we all have ADHD, right? We don't have time to read through a lot of sentences. So we try to make it as kind of brief, bulleted point and simple to use as possible.
There's a number of these tools out there, and listeners who've heard it here on the podcast when we've done, as these have evolved over the years, bringing them to you and helping you understand what's available out there for you to use, for you to reference. And as Dr. Lowe mentioned, you do not have to be an ACEP member to access these. These are open source for all physicians and healthcare professionals out there to for the benefit of our patients. And so I think it's, often we talk about member benefits, but sometimes it's just a community and public benefit, which is what these are, and accessing them, and of course with the innovation and development of AI, of pulling these in and making them even more functional and accessible. So it's nice and broken down in there. It includes every type of disposition that you're going to be looking at, the discharges, because that is one of the nice things about high flow nasal cannulas, is that, especially with the pediatric patients, is that increased opportunity for them to even go home, bridging them a little bit, the croup patient. So the opportunity for them to avoid admission altogether. So it talks about it here, the patient disposition, the discharge from the ED, a floor observation, ICU, transfer, and even talking about some of the palliative care and hospice. So as we kind of wrap up and everything today, we've got the kind of tool talked about, we've got Renovate talked about, implementing this into your practice, and any final messages for the physicians and other healthcare professionals that are out there that are getting geared up for our respiratory season 25-26.
Yeah, I think the best thing the Renovate trial did for my practice, it made me much more comfortable using high flow in that undifferentiated shorter breath patient. The cancer patients you usually know in advance, but whether a patient comes in with COPD, COVID, ARDS, it's even heart failure, sometimes it's all mixed up and you just don't have that initial answer. And this tool has been shown to be non-inferior to non-invasive ventilation in all those populations. So it can be something I can grab as I'm trying to get more information, buy some time, figure out what's really going on. And I think that really changes my practice, because I don't need the exact answer on why they're short of breath. I just have a tool that I can use in that respiratory distress, kind of hypoxic patient.
Yeah, and I would echo that. Both myself and my partners, when I talk to them, it really, I think, added confidence that there's another tool that actually there is evidence behind. The patients appreciate it because they don't feel they're suffocated. From a disposition perspective, at least in our institution, people who are on BiPAP oftentimes have to go to the ICU, and that's a limited commodity. Whereas if there's high flow nasal cannula, they can go even to the floors, depending on what you're dealing with. So from a resource utilization, it's fantastic. And as my partners have gotten much more comfortable with it, we see kind of expanded use. And I think this trial just really kind of hammers home that, not only is what you're seeing is true, but there's actually evidence behind to say it's actually safe to use and, as effective in a lot of these conditions as BiPAP.
And we actually did that in the last week shifts. I've had two patients that threw on high flow nasal cannula, did a recheck after an hour to make sure they're going the right direction, and one avoided an invasive airway, and then two avoided an ICU admission because they got to go to the floor. It was acute on chronic respiratory failure, which here in Kentucky is very common because of our smoking, asthma, COPD rates, and all those types of things. But it is an opportunity to, one, make them more comfortable, two, keep some of those beds available, even though, as Debbie already mentioned, we're already full and we haven't even gotten to the infection season yet in terms of significance. But it does really give us another opportunity and tool now within the emergency department. And I think that is not a lot of good things came out of COVID, but I think one of the good things is most of us in the emergency department have increased access to high flow nasal cannula now. Whereas at least when we started in 2019 rolling into 2020, that was something they actually almost had to be already in the hospital to get access to. So that is going to be nice. How can folks get in touch with you all if they have any further questions about the technology, what it means, and how to implement it in their emergency department?
Yeah, feel free to email me, deborah.diercks@utsouthwestern.edu, and I'm happy to answer any question I can.
Same here, Brucelo1, BRUCELO, the number 1 at yahoo.com. I know who still uses Yahoo, right? But feel free to reach out. I'm happy to answer questions, and not only from my experience, but at least from our institution across all 12 hospitals, how we utilize high flow, how it's changed our practice. I'm happy to share those experiences also.
Well, I mean, everybody's got Yahoo. Was yours like one of the original Yahoos that came out of Prodigy?
Yes, it was. It was.
Because mine was
classic. It's a vintage.
Yeah.
I've got a classic Yahoo that was a Prodigy email, and just a few weeks ago, got an interview with somebody who had an AOL account, and I think those have now been vanquished because there was like 150,000 people had them, and that was it. But the days of the dial-up internet are gone, and getting your disc with 10 to 20 free hours of access, and if God forbid you struck the lottery and you got the 100-hour disc, that was the way to go. Kids, you don't understand what you're missing out on with your high-speed internet and such. But I appreciate both of y'all being there. Deb, are you a foodie as well? Because
I am, but I can't keep up with Bruce, man. His taste is too expensive for me.
Bruce is a new level of foodie. The times I've gone to Michelin restaurants, I only had 2 kidneys, so I've only been able to go twice, just simply selling them. But incredible foodie. So if you want to contact Bruce and find some of the best restaurants around the country and around the world, you can do so because he's probably been there. But as for me, you can contact me, rstanton@acep.org, rstanton@acep.org, at EverydayMed on X. We'll make sure everybody is subscribed to the podcast. Leave us positive feedback, give us 5 stars, and give us some feedback. Let us know what you want to hear, what you want to see, and we appreciate you tuning in. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all alone. Da, da, da.